Like that 2-year cutoff sort of reminded me of that. Like, okay, we send a patient for a hip preservation, surgical intervention. Like, does that need to occur before 2 years or after 2 years? And if after 2 years happens, are they going to have worse outcomes than before too? So, just interesting kind of delineation in time. But I've got 3 quick non-operative cases, all with MRI confirmed labral tears. And I kind of picked three females, kind of an acute, a mid, and then a longer term diagnoses. My first one, she had symptoms really acutely for 2 days. So she is 6 weeks post a hysterectomy. Interesting that we bring up a lot of like pelvic floor and OBGYN diagnoses. And as well as some hip spine conditions, because all these patients can kind of be like blurred in the realm of, is this pelvic floor, is this spine, is this extra-articular hip, is this intra-articular hip? But she went for a 2-mile jog 6 weeks after her hysterectomy and went to OB, got cleared for activity, boom, ended up with this like acute glute irritability. Saw pretty quick our local hip specialist, has an MRI confirmed tear, but kind of some differential with her was, hey, do you just have this like irritable glute from this quick return of activity? Do you have this funny lumbar referral? Is your pelvic floor still involved? All of that information in the presence of an MRI confirmed tear. Versus my second case, her symptoms are a little more classic, like 3 to 4 months, not an acute mechanism, more insidious, but worse with things like running, squatting, lunging, deeper flexion positions. Kind of in terms of what other anterior hip structures could be going on. Is this an iliopsoas, irritability, hip flexor strain? Or as my last patient, longer symptoms. So she kind of falls into that 2-year plus category. She's had PT previously. She has seen PCP. She's seen neuro. She's also seen our local hip specialist. So she has seen all of the providers. So she kind of is the person that has seen multiple providers and is now in this like over 2-year symptom duration. Her symptoms were a little bit cloudy in terms of some lumbar contribution because she had some previous lower extremity numbness that has cleared up currently, but symptoms still can be reproduced with some lumbar-directed intervention. So for the 3 of them, classically, like pain with hip internal rotation. My first girl really had better, like more preserved motion as in terms of the my second patient and my third patient, a little more irritable, a bit more guarded. I think common for all of these patients is they have really crappy glutes. So kind of in between like half to 2/3 of their hip abduction strength, we can compare side to side. There, from a symptom perspective, my first patient was more like crummy feeling and glute med, TFL, kind of some lateral hip soft tissue. My second patient has a lot of like proximal rectus femoris irritability, whereas my third patient, some blurry potential lumbar contributions. She gets some of her symptoms with L3 UPAs, but also can get her familiar hip symptoms with doing like an inferior or posterior joint mobilization. So again, another rabbit hole of hip spine, but totally real. These patients come with lots of different baggage and lots of history. Their patient-reported outcomes are listed, and I think also common theme for all of these patients, they have a hard time really like recruiting their glute without some potential like anterior hip and TFL compensation. So I think that leads to them feeling really just sore in their anterior hip. They have to have a lot of posterior capsule mobility work, some management of soft tissue irritability, whether that be lacrosse ball foam rolling, dry needling. I think they tend to not do as well with some repeated tensioning and stretching over their anterior hip, as we've kind of seen in some of the conversations you guys had. And maybe us just chronically tensioning their anterior hip over time, potentially thinking they have a hip flexor involvement, is just doing them a disservice. They don't have a motion issue. They've got a soft tissue issue that's just making them feel lousy. But our rehab theme was really progressive glute loading from open chain to closed chain. Lots of work spent with these patients on just how do I figure out how to get my glute to turn on versus my quad and hamstring or my TFL vastus lateralis, all try to contribute into making my hip work. And then graded activity return. So quick outcome on these 3 patients. My first patient did well. She had probably the biggest substantial hip strength improvement. best reported outcome improvement. Interestingly, after her hysterectomy, she then went later for a prolapse repair. She had an upcoming hip consult, so still dealing with some of her intra-articular hip issues, but kind of took a back burner to some of her other pelvic floor and OBGYN dysfunction. My second patient has surgery scheduled. She was probably the best example of, hey, let's do a trial of therapy plus injection plus some anti-inflammatories. Let's see how you do. Her and I have met sporadically over the last couple of months, and I've been able to make some progress in her hip strength, but really her motion is lousy. Her daily activities that are uncomfortable are still uncomfortable, and she's got surgery scheduled when it most fits into her work life in the next couple of months. And then the last patient, her and I are still working together. She's made some improvement in her glute strength, some improvement in her hip motion, but she also has an upcoming hip consult, and I think will be another interesting person to discuss with, hey, is it time for us to go down the surgical route, given that we've done this extensive PT, not only currently, but in the past. She's been worked up by multiple providers. But again, kind of approaching that 2-year window of, hey, are my outcomes not going to be as favorable now that she's kind of in this long-term symptom category as compared to some of my more acute patients. But those are the 3 that I have. I think, great to hear you guys in terms of some differential, some things that have gone well, some things that haven't gone well in your practice. And I'd be interested actually if these are some common symptoms and themes that you've seen with some of the patients that you share with Dr. Bird, or even Dr. Cristoforetti. Are these some common complaints that you see with patients when they come see you for their consult?
Yeah, I mean, I honestly couldn't have done a better job of putting that 3 really great examples of very classic. I mean, we mentioned some outlier type of situations, but really great examples of variation of what we see and kind of how those things can play out. So it's funny, obviously the more you do it, I was oh, patient number 2 is gonna have surgery. The moment you put it up, I was number 2 is having surgery. So that's awesome. So thank you for sharing that.
And Abigail, I was going to say the same thing. Thank you very much. In that you also illustrated a lot of the points that we're talking about, looking at these things, doing a trial, or looking at things from a broad perspective, and then saying, yep, this one has to go back. This one has to be worked up for their hip more. So on. That was really good illustration of that. Thank you.
I would just say that just for the 300 so plus participants still on, we didn't do a rehearsal, and we didn't know what we were going to talk about, did we? And you work with an expert hip surgeon named